Welcome to our third blog. In our second one, we talked about compassion and the paradox of being compassionate in a service which had lots of constraints. And we also talked about the importance of trust and for medical leaders to maintain trust. And you emphasized how important it was to maintain your integrity.
Yeah.
So in this one, I'd like us to talk a little bit more about how you are challenged and how you manage the tensions between being compassionate and leading in this really constrained environment, especially focusing on how you take thoughtful action to help the staff and the patients in the context of a very constrained environment.
Yeah, and I think the reason we're talking about this is because in the last conversation we had, I talked about being honest about saying we can't meet the needs or can't take action. But this is an opportunity to talk about what we might be able to actually do in the context of our current constraints.
So what you also mentioned that you are a real quality observer of quality and take it really seriously, and you stand your ground around quality. What informs your view of quality?
So quality of care, which is common theme throughout all of this, of course, is key to this. And I'm a simple clinician and like definitions to help me anchor conversations and dialogue. In the NHS currently, the definition that is becoming normalized is that through the CQC and their domains, which are safe, caring, responsive, effective, and well-led. Effectively, the domains they use to assess how well an organization delivers care. But I, as a doctor, have used much for a longer period, a different definition that, of course, can relate back to CQC, but this particular definition is also deep in my DNA and comes from the Institute of Medicine. And it is safe, timely, effective, efficient, patient-centered, equitable care. And the reason I'm wedded to this in one sense is that in all the work that I've done, in all the workshops and conversations that I've had, this definition has never been one that's been the one that can be broken. And I particularly like it because it has that domain which is equitable. And in fact, the NHS is trying to do exactly that, provide equitable care.
But it also links to your real value of social justice.
Absolutely. Yeah. So it links to my core value of social justice, and which is why I then refer back mentally or through my DNA to this definition of quality. And important as we now talk through about the challenges of compassion and the constraints.
So let's see how you keep that in mind when you're faced with day-to-day problems of being a medical leader. And I think in using this, we can use Keith Grint's definition of tame, critical, and wicked problems. Can you give us some material around that to help us understand those three types of problems?
Yeah, so I'll use an example of staffing, medical, clinical, doctor, nurse staffing, and see if this works. So tame problems are those that are solvable through a process or by describing a process that needs to be enacted. So we are challenged by our regulators to show a really effective recruitment and retention policy of our staff. And in essence, a problem that we're faced with, we solve it by writing a robust policy that describes processes, so effectively a tame problem that we can deliver through a good quality policy. But at 4 o'clock in the afternoon, we will be faced in the ops room with a crisis, which becomes a critical problem where we're down suddenly, unexpectedly, 2 doctors and 4 nurses for the ED at Queen's, for example. So the teams will work extremely hard to recruit in that moment the doctors and nurses needed to keep our teams safe and through that patient safe. And we'll go out to agencies and we will end up spending more money than we should.
And which you're not really allowed to.
And sometimes we're not allowed to through the caps to solve a critical problem that has become a crisis. So that requires urgency and leadership to engage and make the difficult decisions that are, we're going to spend the money to keep staff safe and patients safe. And then The wicked problem here is, the way I look at it is, we've taken what are effectively tame problems of staffing and made them wicked because of decisions made over many years around workforce strategy for the NHS. So we now work in an environment where an orthopedic team will come and say, we don't have middle grade staff to cover the wards to keep patients safe or keep us confident that patients are kept safe, help us recruit. And I will say, but there aren't the doctors out there. And HE or Health Education England has determined how it's going to spread the trained doctors. And we are then challenged with having to find different workforce solutions, but actually even the new medical schools and places will take years to generate the more doctors we need. And in the face of a Home Office that is refusing visas for resources of expert people we need, this has become an extraordinary wicked problem for us. And the question then is, how do I address that when colleagues come and say, I need people to
can't do our work. We can't do our work. So let's translate that into a real operational problem that I'm sure you've experienced that issue around recruitment, but do you have any other examples where you have felt the tension of maintaining your credibility, but also taking thoughtful action in the face of what you consider to be unreasonable demands or constraints?
So I'll give you an example where, in the context of our current financial challenges and constraints in my trust, we have as a medical director, I'm most concerned in one sense about two categories of patients. Patients that come in requiring resuscitation. They're most critically ill. They require extraordinary resources, skills, people, equipment, etc., to rescue them out of that critical state, if that's the right thing to do. And the second category are patients that are on the wards who are gradually or suddenly deteriorating.
So what did you do that's any different to anywhere else?
Well, so most recently we've invested in technology to support our staff to be able to detect that deteriorating patient promptly in order to take the actions promptly. And that required a significant investment, money, to buy the technology. But the other thing that we did as a trust, and over quite a long period of time, like other trusts have done, is establish a critical outreach team that reach into wards to support the staff to save patients that are deteriorating, to provide optimal care. And a conversation that we found ourselves in with a regulator was that the critical outreach team wasn't commissioned.
Now, this is not new staff. This is staff who are doing other jobs until they're called. An
existing team who are part of the intensive care team, who are skilled to be outreach to support staff on wards.
So they're not extra expense.
Well, they are an extra resource for the wards when needed, when there's a deteriorating patient. So they are effectively second responders in one sense, or immediate responders. But they're not commissioned to do that. So that work isn't recognised and therefore not paid for by the commissioners. And the question asked was, so if it's not commissioned, why are you doing it? When that statement was made, it was really interesting to be in the room because there was a moment of silence. For lots of reasons, an extraordinary question perhaps in some people's minds, incredulity at the question in some other people's minds, but I also concluded this potentially wasn't a psychologically safe place suddenly to be able to challenge easily a regulator asking the question. But actually it was really clear, because everybody else in the room was a clinician, active working clinician, who clearly held to their integrity and, as I did, say, well, actually, the right thing to do is to maintain the service, to serve our most vulnerable patients. The issue of the commissioning is something we'll have to solve, if we need to solve it, in a different sphere or a different environment. But right now, we're not going to let go of what is the right thing to do. So
it was intelligent action, wasn't it?
It was absolutely the right action to take.
Yeah.
So maintaining my integrity and those of my colleagues was really fundamental to being the type of leader that people talk about, which is the compassionate leadership, building trust. If you don't have that integrity rooted to your values, then you're going to fail in your duty as a medical leader.
And not support quality care.
And actually fail to deliver quality care.
Thanks, Nadeem.
Thank you.
Follow us on Twitter and LinkedIn and look out for our 4th blog.
Which will be published on Twitter and in LinkedIn.